Hello everyone, I am Zeinab Ahmed Saad of Memorial Institute of Ophthalmic Research. I'd like to discuss with you how to approach a case of ptosis, and I'd like to simplify it for young ophthalmologists. As ptosis has been discussed in many books and classified into congenital, acquired, myogenic, neurogenic, mechanical, and involutional. But how to evaluate a case of ptosis coming to your clinic? What to do? In order to simplify it for you, I did it as a rule of three, approaching a case of ptosis as a rule of three, starting with history. Ask about 3 onset, course, and past history. Then exclude pseudoptosis. 3 lack of support, hypotropia, lid retraction. Then search for 3 Bell's phenomena, Marcus gun, and corneal sensation. Then examine bilaterality, pupil, and ocular motility. Then measure MRD, levator function, upper lid crease. Then exclude secondary ptosis, 2 myasthenia gravis, congenital fibrosis, or myotonia dystrophia. Then if you have in your clinic a patient with bilateral symmetrical ptosis, then you should search for third nerve palsy with nuclear origin, or chronic progressive external ophthalmoplegia, or blepharophimosis. Starting with the history, we should ask about the onset to differentiate between congenital and acquired. Then the variability of the course to exclude myasthenia gravis. Then ask about the past history of trauma, surgery, or tumors to exclude mechanical ptosis, and then ask about drugs to exclude diseases that leads to dry eye. Then pseudoptosis, you should exclude lack of support, hypotropia, and lid retraction. This photo here demonstrating that normally the lateral orbital wall is at the level of the equator of the globe. Then when the patient is suffering from microphthalmia, atrophia bulbi, or cysts bulbi, the globe will be embedded into the orbit. As a lack of support, it will cause a pseudoptosis. As shown here in the photo of the child, he has left microphthalmia and pseudoptosis. The other photo here is confusing. Either this is a right upper lid retraction or left ptosis. But by knowing that normally the upper lid cover 2 mm of the upper cornea, we should know here that this is a right upper lid retraction rather than left ptosis. This child came to my clinic complaining of right ptosis. When cover and cover test is done for her, it reveals right hypotropia and MED, or monocular elevation deficit syndrome with restrictive type. So I did for her inferior rectus recession, and as the eye globe got upward, the upper lid position was improved. Then search for Bell's phenomena, Marcus gun, and corneal sensation. These 3 topics or these 3 items is very important as it affects our decision in surgery. Bell's phenomena, we all know it, as the eye globe moves upward while closing the eye. Marcus gun is a misdirection of a mandibular nerve branch to the levator muscle. So while the patient chewing or moving the jaw, the eyelid would move simultaneously. Then test for corneal sensation by using a cotton tip to exclude any hypothesia or anesthesia. Then examine 3 bilaterality, pupil, and ocular motility. Ocular motility to exclude third nerve palsy, chronic progressive external ophthalmoplegia, or congenital fibrosis. And then examine pupil to exclude Horner or third nerve palsy, either sparing or affecting the pupil. Then bilaterality you should ask yourself, is this a unilateral ptosis or a bilateral ptosis? So how to discover it? You should elevate the ptotic eye and observe the other eye for any upper lid drooping. If you observed any upper lid drooping in the other eye, then you know that this is a bilateral symmetrical ptosis, and you should warn the patient that he may need bilateral surgery. Measurement: MRD, levator function, and upper lid crease. Marginal reflex distance is the distance between the corneal reflex and the upper lid margin, which is normally about 4 to 4.5 millimeter. 2 millimeter ptosis of the upper eyelid is a mild ptosis, while 3 millimeter ptosis of the upper eyelid is moderate ptosis, while 4 millimeter ptosis is severe as it is covering the pupil. Levator function is mandatory to decide for the decision of the operation. It is done by instructing the patient to look downward while putting the thumb on the eyebrow to negate any frontalis action, and then ask the patient to look upward and then measure the upper lid excursion distance. And here is 2 examples of the levator function. The upper photo shows that the right lid reveals a high upper lid crease, but a good levator function. The lower lid, which is also involutional ptosis, but there is no lid crease at all, and a deep sulcus, but it is showing that she had a very poor levator function. As congenital ptosis is one of the commonest causes of ptosis, so levator function should properly be evaluated. Congenital ptosis characterized by poor levator function, as we can see here in the photo. Also, it is characterized by absent lid crease and lid lag on down gaze. Congenital ptosis is considered one of the diseases of the CCDD, which is congenital cranial dysinnervation disorder syndrome, and it is characterized by dysinnervation but also levator muscle fibrosis. So the lid can't go upward or downward. Then exclude secondary ptosis to myasthenia gravis, congenital fibrosis, and myotonia dystrophia. Also, this is very important because it affects our management. Here is a case of 20 years old female patient. She was presented to our clinic complaining of left ptosis, and she was known to have thyroid ophthalmopathy. I'd like to emphasize here that thyroid eye diseases is an autoimmune disease and can be associated with other autoimmune disease like myasthenia gravis. So if you have a patient with thyroid eye disease and exotropia, or thyroid eye disease and ptosis, which is uncommon, you should think about myasthenia and you should exclude it. So I did for her a lid fatigue test and it was positive, and eye spec test and also it was positive. I'd like to say here that eye spec test is a pathognomonic test for myasthenia gravis, unlike lid fatigue. So she was having myasthenia gravis also. Also exclude secondary ptosis to congenital fibrosis and secondary ptosis to myotonia dystrophia, which you can know it by knowing that the patient will be in his third decade, and also by shaking hands. If you have in your clinic a patient with bilateral symmetrical ptosis, which is uncommon, then you should think about three diseases like third nerve palsy with nuclear origin, as the nucleus of the levator muscle supply both levator muscles, and the chronic progressive external ophthalmoplegia, as we can see here in the photo, and blepharophimosis. Blepharophimosis is characterized by bilateral symmetrical ptosis. Also, it is one of the autosomal dominant diseases. So when you see a blepharophimosis, you should know that his father or one of his family members should have it. If you didn't find it in his brother or sisters or father or mother, so you should think again. It may be simple congenital ptosis only. Also, it is characterized by telecanthus, which is a long distance between the two inner canthi, as I demonstrated it here with a white line, and a short horizontal palpebral fissure and epicanthus inversus. So to simplify it for you, rule of three in history and exclude ptosis and search for three items which affect our decision and examine three and measure three and exclude secondaries. I think this will make it easy for you that you will evaluate any case of ptosis and make it easy for you. I hope you enjoy it. Thank you.